Good evening. We've invited 3 expert speakers as our panelists to review how Medicare works, explain how it's being privatized, reveal how profit is being extracted from this vital nonprofit public program, and answer your questions. The webinar is co-sponsored by CARA, the California Alliance for Retired Americans. The League of Women Voters of Berkeley, Albany, Emeryville is a nonpartisan political organization. In this critically important election year, we invite those interested to join us. To learn more, please visit our website at lwvbae.org. We exist to empower voters and defend democracy. Please join us. Now, about some rules around the seminar here. Please only use the Q&A for your questions. That's where you should enter those even while the speakers are presenting. We will have sessions in between for those questions. Please also ignore the chat and don't bother raising your hands. We've turned off that function. And now we'll begin.
Thank you, everybody, for coming. I'm Hank Abrons, co-chair of the local league healthcare team, and it's my pleasure to introduce Dr. Anna Malinow. Anna is a longtime leader in the single-payer movement, and she is the lead organizer for National Single Payer and for the movement to end privatization of Medicare. Anna, the floor is yours.
Thank you, Hank. Let me share my screen. And get this going. Okay, great. Can everybody see my screen? And everybody can hear me, I hope.
Yes.
Well, thank you, Hank, for that introduction, and thank you to the Berkeley, Albany, Emory League of Women Voters, as well as to CARA for inviting me to speak with you today about privatization of Medicare, from the boardroom to the exam room, privatization of Medicare, and the menace of value-based payment. Now, in the next 30 minutes or so, I will discuss a brief overview of Medicare, how it works, how it's being privatized, how profit is being extracted, the impacts it has on quality, the menace of value-based care, and the way forward. It's a complicated subject, so please stay with me and let's get right to it. So, part 1, taking advantage of Medicare. Now, in 1965, Medicare started as Part A and Part B, what we know and call traditional or original Medicare, as well as a Part B supplemental policy or plan. Now, Part A is automatically, it's coverage that anybody who turns 65 gets upon turning 65, as long as they've paid into Social Security for 10 years. There are no monthly premiums for Part A, and it covers 100% of coverage of hospital costs. Now, although there is a deductible. Now, Part B is not automatic. It's voluntary health insurance, so you have to sign up. And it comes with monthly premiums of about $170 per month, depending on your income. And it covers only 80% of your outpatient costs. As a result of the fact that Part B only covers 80% of outpatient costs, a Part B supplemental plan, which is a private health insurance option that most individuals on Part A and B purchase, will pay the 20% that Part B doesn't cover. Now, this supplemental policy is usually paid for either by the employer, by the union, or by Medicaid, if the beneficiary is eligible for Medicare and Medicaid. And then also there are individuals that have to pay out of pocket for that private health insurance plan, which ends up being quite expensive. Now, over the years, more people qualified and more parts were added to Medicare, including a Part C, a Part D, and then Medicare Advantage, which is the new name for Part C. Now, Part C was added as a private health insurance option for beneficiaries on Medicare who wanted to have private health insurance instead of the Part A and B. And the idea was that because this was private, that it would improve outcomes and lower costs. And beneficiaries could choose the Part C instead of A and B. Now, Part D was added in 2003 to pay for prescription drugs in a very convoluted way, and it comes with monthly premiums and deductibles. And then Medicare Advantage was the new name for Part C as of 2003, and that is the private health insurance option that comes with usually low or no monthly premiums and extras such as hearing, vision, dental, some gym memberships. But for those extras, you have to accept and for those low or no monthly premiums, you have to accept narrow networks and prior authorizations. And let me just mention that there are low or no monthly premiums, but people on Medicare Advantage still need to pay the Part B monthly premiums according to their income. Now, to see just how much money is in the system today, let's take a look at total Medicare spending from 1970 to and every 5 years to today. Now, the Medicare spending started in 1965 with a $10 billion budget. It went down a little bit, but you can see that it's been going up quite a bit every year since then. So the budget that started in 1965 with $10 billion today is almost $1,000 billion. Now, you can say the number of Medicare beneficiaries since the beginning has also gone up, and you would be right. Enrollment in Medicare has been going up from 1966 when it started with about 20 million beneficiaries, and every year it has been going up gradually, so that what started in 1965 with 20 million beneficiaries stands today at 65 million beneficiaries. However, since 1965, the total number of Medicare beneficiaries has increased threefold, but costs have increased 100-fold. Now, the question of why spending is going up has troubled American health policy experts for over 50 years. And according to these health experts, there are two reasons why costs keep going up. One is greedy American doctors that order too many tests and perform too many procedures. And two, greedy American patients who see too many doctors, ask for too many tests, and get too many procedures. And you can see the typical greedy American patient in this cartoon hooked up to his condensed chef salad through his IV. Now, this is facilitated by something called fee-for-service, which, according to American health policy experts, is the reason healthcare costs keep going up. But what is fee-for-service? Well, fee-for-service is actually not that complicated. It's the way doctors get reimbursed under traditional or original Medicare. If you have traditional Medicare, you go to your doctor who performs a service, who then bills Medicare for that service, and Medicare then pays the doctor directly. Nobody between you and the doctor, and nobody between the doctor and Medicare. Just a straight arrow. Nevertheless, fee-for-service has been blamed for America's high healthcare costs compared to peer nations for the past 50 years. But let's look at a couple of these myths closely. Now, some people say our costs are high because we use fee-for-service. But if you look at other countries who also use fee-for-service and compare their healthcare costs as a percent of gross domestic product, you can see that over time there, you can see the timeline from 1983 to about 2017. The black line above, which represents US healthcare costs, are much higher than the colorful lines below, which are the healthcare costs of peer nations such as France, Germany, Sweden, Canada, Japan, etc. All these countries also reimburse their doctors using fee-for-service, and as you can see, spend much less than the US. Now, another myth is that our costs are high because we just get too much care, those greedy American patients and those greedy American doctors. But if you ask Americans, what percent have skipped needed medical care due to costs in the past 12 months, you see that 33% of Americans skip care compared to much lower percentages of people in other countries, to a low of 7% in Germany and in the UK. Now, this data is from 2016, but in October, the Commonwealth Fund published another poll that showed that in 2022, 38% or almost 40% of Americans skipped care due to cost. Now, in addition, when compared to other countries, Per capita, the US has fewer physicians, fewer nurses, fewer hospital beds, shorter hospital stays. We visit the doctor no more than the median country and graduate fewer doctors. The bottom line is that all of these myths about fee-for-service and greedy patients and greedy doctors causing our high healthcare costs are busted. Now, just a very brief note, you will see that almost all my slides have references at the bottom. This is all based on evidence. It might sound like I'm making some of this stuff up, but I'm really not. Now, since the 1970s, American health policy experts believe that the way to control healthcare costs, ostensibly caused by fee-for-service, is before we get to the health policy experts, let me just say that if it's not fee-for-service or higher utilization that is causing our healthcare services, what does drive up our healthcare costs in the US, and number one culprit is price. And then which in turn are driven up by rising consolidation and administrative costs. And consolidation makes it easier to raise prices for any reason. Greed, rising administrative costs, and rising administrative costs give all the sellers the motive to raise prices. So these are the true drivers of healthcare costs being so high in the US and not fee-for-service. But nevertheless, as I said, since the 1970s, American health policy experts believe that the way to control healthcare costs caused by fee-for-service is for Medicare to pay a middleman to manage the care of seniors. And this middleman accepts to share the risk or take the full risk of covering a member's healthcare costs and decides who gets what, when, where, and then pays the doctor, the hospital, the providers, and gets to keep a percentage of the leftovers. Now, over the years, these middlemen have been called health maintenance organizations, Medicare Advantage, and as we will see, accountable care organizations and ACO REACH. Now, not all middlemen are for profit. However, all middlemen exist to manage care and receive financial incentives to control costs. Now, hardly a week goes by without news about corporate middlemen in Medicare. And I'm going to run through several examples very quickly. Many of you already know these. You probably sent me these articles and have read them yourselves, but this is just to show you how extensively corporations have taken advantage of Medicare. Now, executives and investors from more than 400 health systems and companies arrived in San Francisco last week for the 2024 JP Morgan Healthcare Conference to discuss the industry's most pressing issues. Keynote speakers included Jamie Dimon and Tony Blair. Last month, Medscape reported that 10% of US physicians work for or under United Healthcare. BrightSpring Health, a home health services provider operating in 50 states, filed plans for an initial public offering with the Securities and Exchange Commission, citing opportunities for growth rate to an aging population in need of long-term care. And who's going to be financing this? Well, the giant private equity group, KKR, Morgan Stanley, UBS, Bank of America, and so forth. Private equity-backed staffing firms now run 25% of the nation's emergency rooms, and other estimates put private equity's penetrations of ER as high as 40%. Boston-based Mass General Brigham plans to use Best Buy's current health technology platform to advance at-home health. And who knows? The Geek Squad will one day help you with your technology needs and possibly your chest pain. Private equity is getting rich off hospice through recruitment of patients who are ineligible for hospice care and thus lose access to curative or emergency care. And in this study that was just published last month, private equity acquisition was associated with a 25% increase in adverse outcomes, despite the fact that private equity-owned hospitals serve younger and wealthier patients. Now, corporations will fleece you in your primary care office, in the emergency room, in hospice, and finally in the funeral home. There is not one part of our lives that corporations haven't commodified for their profit. Now, there is ample evidence that profit is bad for health. I will just look at 3 institutions: dialysis, hospice, and nursing homes. So for-profit dialysis own about 95% of all dialysis centers in the US. 3,800 excess deaths could be averted every year in the US if all dialysis patients were treated at not-for-profit centers. Now, 2/3 of all hospice are owned by for-profit companies, and we know that for-profit status is associated with fewer services, more formal complaints, more discharges of sicker patients, and more hospital and emergency room use. The vast majority of nursing homes are owned by for-profit companies. For-profit nursing homes skimp on nursing care and have more citations for quality deficiencies and have higher death rate than nursing homes run by not-for-profit systems. Now, another way of talking about transferring public Medicare money to middlemen is privatization, which is defined as the transfer of public goods or public funds to private hands. And we can see just how much Medicare has been privatized before 2003, when most beneficiaries on Medicare, those represented in blue in this pie, chose to remain on traditional Medicare, known as A and B, and only a very small slice in green chose a private health insurance option, then known as C, to manage their care. But if we fast forward to 2023, you can see that 50% or over 50% of beneficiaries now choose Medicare Advantage to manage their care. And then the other 50% remain in traditional Part A and B Medicare. These are the individuals who want to be able to choose any doctor and hospital without having to ask for prior authorization, and they pay extra for this. So 50% of Medicare is already privatized. That's the green part. What is at risk of being privatized now is the blue part of the pie, traditional Medicare. And this is the piece of the pie where we're going to be focusing our attention for the rest of this talk. The menace of value-based care. Now, to be fair, healthcare costs are high, but the Centers for Medicare and Medicaid Services, also known as CMS, has the wrong diagnosis that healthcare costs are high because we reimburse providers using fee-for-service, or that patients get too much healthcare. And as every doctor and every patient knows, if you have the wrong diagnosis, your prescription is likely to be wrong as well. And instead of looking at the real drivers of runaway costs, which we saw were prices and consolidation and administration, and proposing a worldwide evidence-based solution, such as single payer, CMS decided to control Medicare costs allegedly caused by fee-for-service and Medicare Advantage, that's the green piece of the pie, by paying commercial plans through something known as capitation, or monthly payments for each beneficiary to cover all healthcare costs. Now, needless to say, commercial plans love this per beneficiary per month payment because that gives them plenty of opportunity to cheat and game the system and keep the leftovers. Anywhere from $88 billion to $140 billion per year, according to a recent PNHP study. And in traditional Medicare, the blue slice of the pie, the Affordable Care Act, so this is the Affordable Care Act, established something called value-based payment and accountable care organizations. And that's the emphasis on value and accountable and care. Medicare would now pay for value instead of for volume. It would finally abandon fee-for-service and address the twin problems of quality and cost. Little did they know how much more fraud there could be in value than in volume, or maybe they did. Now let's take a little time out and define a few terms before we go any further. Question is, what is value? Well, value is good. No one is going to argue that. But if we are going to base our payment on value, because it's value-based payment, then we will have to measure value to pay for it. And how do we measure value? We're much more likely to choose something that is easily measured, such as blood pressure, than happiness or social support, which could be just as important to your heart health. So already our value measurement will be biased and not necessarily a reflection of true value. Then the question is, okay, we will just measure what is measurable, but there are over 10,000 CPT codes. Those are the codes that all providers use for medical services for reimbursement. We can't possibly measure everything, so we will just choose a sample of measurable services among those 10,000 services. And what happens to the services not measured? Well, experience shows us that doctors stop paying attention to the unmeasured services and pay a lot more attention to the services being measured. They teach to the test. And in a system that rewards physicians for value, what happens when a patient sees multiple doctors? And it's not cheap. Physician practices spend about $40,000 per doctor per year, or over $15 billion per year to report quality measures. That's just to report on quality, not to improve it. If value can't be defined or measured, should it really be the metric to reimburse and reward medical care? Well, apparently so. Now, the next big question is, what is an accountable care organization exactly? The formal definition comes from the Affordable Care Act, but my definition is this. An ACO is a middleman between Medicare and the provider who agrees to assume financial risk for somebody on traditional Medicare to manage the care of beneficiaries on fee-for-service traditional Medicare, who agrees to meet certain quality or value measures, and then to share the savings. Now, if this sounds anything like Medicare Advantage to you, well, that's because it is very much like Medicare Advantage. But did I mention that seniors are assigned to an ACO without their knowledge or consent? Right, that's the difference between Medicare Advantage and an ACO. So now that we have these definitions out of the way, let's answer the questions. What is value-based payment? Is it different from value-based care? And why should we care? Now, all value-based payment does three things. One, they all insert a middleman between Medicare and the provider to manage care. Two, they all use performance measures to financially incentivize doctors. And three, they all set up spending targets, also known as benchmarks. Now, we're going to go through these one by one. But again, this is what is happening in traditional Medicare that never had a middleman. One, all value-based payment inserts a middleman into traditional Medicare. Remember, traditional Medicare is fee-for-service. Remember that slide I showed you, without a middleman, the direct arrow. Now there's a middleman who manages care and shares the risk of covering the medical costs of seniors and typically extracts profit. The difference between this middleman and those in Medicare Advantage is that now, by becoming accountable, the doctors also share the financial risk, and increasing financial risk for the doctor means the doctor is now on the hook to produce savings, especially since doctors are still reimbursed by fee-for-service, but at a lower rate. Remember, these are seniors who rejected Medicare Advantage and are willing to pay more so they do not have to deal with a middleman managing their care. Two, all value-based payment ties the doctor's financial incentives to performance measures such as quality, health outcomes, and cost. All of these are good, but remember, quality or value are difficult to measure. Which health outcomes will you choose? And what happens if a patient sees multiple doctors? How well these doctors perform on value metrics determines how much savings they share. Value-based undermines the relationship between the doctor and the patient, making the patient ask, whose best interest does the doctor have? Mine or the ACO? Three, all value-based payment sets up spending targets, also known as benchmarks, for every traditional Medicare beneficiary in their panel. So if doctors and middlemen come in under the target, they increase the savings, meaning their profits. But if they come in over the target, depending on the financial arrangement they have with Medicare, they might owe Medicare money. So let's take an example. Medicare gives value-based company Good Profit $1,000 to take care of Mr. Jones each month. If the Good Profit doctor only spends $800 on Mr. Jones that month, Good Profit and the doctor save $200 and get to keep a certain percentage of the $200 as profit. If, however, the Good Profit doctor spends $1,200 on Mr. Jones that month, Good Profit and the doctor owe Medicare $200. How much they owe depends on the financial arrangement with Medicare. Our competitive healthcare system is driving doctors to sign up with ACOs and then driving them out of the profession due to burnout. And the next time you try to find a PCP and can't, value-based payment might be one of those reasons. Now, we care about value-less payment because financial incentives motivate doctors and middlemen to deny and skimp on care to maximize profit, to seek healthy patients who cost little, to cherry pick the ones who predictably only cost $500 a month while Medicare still gives that ACO $1,000 a month. Avoid sick ones who cost a lot. That is lemon drop the ones who predictably cost $3,000 every month, even though they're only getting $1,000 to cover that patient. Upcode, which is a trick perfected by Medicare Advantage to add diagnoses to patients to get higher payments for healthy patients without spending a penny more on their care. So to try to get $2,000 for that Mrs. Smith who only cost them $500 a month, and then only spend $500 a month on her. For physicians, we know the complexity of value-based payment arrangements accelerates the shift away from physician-owned practices to practices owned by hospitals, healthcare systems, or insurers. The middlemen wanting to maximize their own profits will avoid doctors who take care of sick or poor patients. And for the system, physician burnout and physician shortage, lack of primary care, and worse, equity. And this is why we care about value-less payment. Now, here goes the 1-minute elevator speech on value-less payment. Number one, and very, very, very important, value-based payment has nothing to do with value. It inserts a middleman between Medicare and beneficiaries on traditional Medicare. It shifts the financial risk from Medicare to doctors. It rewards doctors financially for meeting performance measures and for spending underspending targets. It's managed care all over again. It incentivizes cheating, skimping on care, cherry-picking healthy patients, lemon-dropping sick ones, upcoding patient diagnoses, and greater inequity. Now, don't worry if you're confused. I imagine that everyone has seen The Godfather, right? And if you haven't, please rent it tonight and watch it. All of this will become much clearer for you if you do. So remember Vito Corleone, the Godfather? Well, he is value-based payment, the big overarching concept. It's the new payment that replaces fee-for-service. And value-based care is a way to deliver care using value-based payment. Michael is value-based accountable care organizations. And Fredo, the incompetent son, is ACO REACH, a tiny family spinoff, one of the value-based models we will be looking at in a bit. Now, according to the CMS website, there are currently 456 accountable care organizations in traditional Medicare, serving almost 11 million beneficiaries, which means that about a third of the beneficiaries on traditional Medicare have been assigned to ACOs without their knowledge. An important study just published in the Journal of the American Medical Association found that ACOs were associated with net losses to traditional Medicare, up to $1.4 billion during their 9-year study period. Now, let's switch over to ACO REACH, which is a typical value-based care model. ACO REACH started as direct contracting entities under the Trump administration. It was green-lighted by the Biden administration as ACO, which stands for Accountable Care Organizations, REACH, reaching equity, access, and community health. Just like every value-less payment model, it inserts a middleman, now called an ACO REACH, that agrees to take accountability, that is, share the risk to cover the medical costs for seniors on traditional Medicare and share those savings. Now, what or who are these ACO REACH middlemen? Well, virtually any type of company can apply to be an ACO REACH, including commercial insurers that run Medicare Advantage plans, private equity firms, and venture capital investors. And applicants are approved without any input from Congress. Now, in September of this year, the Congressional Budget Office finally published their first report after 10 years on the value of these value-based models, and found that the models increased Medicare spending by $5.4 billion over 10 years, And not only did the models increase spending in the first 10 years of operation, they will continue to do so into their second decade. Now, let's see how these programs extract profit from Medicare. Under traditional Medicare, remember the straight line, no middleman, providers are paid directly. These administrative costs are 2%, which is about $20 billion per year. If you figure that the Medicare budget for 2024 is about $1,000 billion, that gives patients $980 billion for medical care. Now, under Medicare Advantage, where you have a middleman managing the care of seniors, administration and profits are anywhere from 15 to 17%, which means that that's $150 billion for the corporations, leaving patients about $850 billion for medical care. And under ACO REACH, where a corporation manages the care of seniors on traditional Medicare, administration and profits are at least 25% and as high as 40%, which means that they get $250 billion for administration and profit, leaving just $750 billion for medical care. Now, despite lackluster results and profitization, which is really what this is, according to the Centers for Medicare and Medicaid Services, CMS, this is right out of their website, all traditional Medicare fee-for-service beneficiaries will be in a care relationship with accountability for quality and total cost by 2030. Now, we know what they mean by that. They mean the care relationship is a value-based shared risk payment model with a middleman who is usually extracting profits. All of this by 2030. This means that all Medicare, Advantage and traditional, is threatened by privatization. Now, it has taken us 20 years to go from most Medicare beneficiaries choosing traditional Medicare in the blue to today, where half of Medicare beneficiaries choose Medicare Advantage and the other half choose traditional Medicare. And where CMS has already chosen either ACO REACH for about 4% of beneficiaries, and ACO for 18% of beneficiaries, and by 2030, according to their website, will have chosen some kind of organization accountable to manage the care of all seniors, so that we will have privatization for all. Now, the way forward. I know that Jodi's going to be talking about AJR4, so I just want to mention that on September 7th of this past year, the California State Legislature passed Assembly Joint Resolution 4, making California the first state in the country to go on record opposing ACO REACH and corporate profiteering in Medicare. And I'm sure Jodi is going to talk a lot more about that. I just do want to tell you a tiny bit about the movement to end privatization of Medicare. Our mission is to protect Medicare as a public good, and we meet the first Saturday of every month by Zoom. We are organizing legislative visits, starting with Representatives Mullen, Mark DeSaulnier, and Jared Huffman, and are planning future visits. Our first visits are actually going to be tomorrow by Zoom. We are educating our members of Congress about value-based care, asking them to sign a pledge, supporting Assembly Joint Resolution 4, and to urge President Biden and Secretary Becerra to end all value-based care. If you would like to learn more about our movement and to visit your own member of Congress and ask them to sign the pledge, please email me. I will I guess I can't put that in the chat. At any rate, please email me and I will add you to our growing group of members. And there's my email, annamalinow@gmail.com. So thank you very much. And I think I'm going to be taking some questions now, or let's see, stop sharing. Stop sharing. Great.
Well, Anna, there was a lot in your presentation, and we're starting to get some questions. I want to mention that the link to the recording and a handout with references and other useful material will be emailed to all participants, actually all registrants, whether or not they're present tonight, within a few days after the webinar. So, Anna, the first question is about the impact that high salaries for providers and hospital administrators has in the cost of our healthcare. And the questioner understands that providers in other countries make far less than US providers. Is that true? And what is the impact?
So good question. I would say that the impact is not so much on the salaries that physicians make in the United States, although you are correct in saying, in thinking that compared to some countries, US physicians make more money, but compared, for example, to Canadian physicians, we're pretty much on par with what Canadian physicians make. But what is different is the balance between the number of specialists in this country that do get paid a lot more compared to primary care physicians that in comparison get paid a lot less. And so when you have a healthcare system that is very heavily weighted towards specialists, those specialists get paid more, then you're going to have a healthcare system that is going to be paying higher salaries compared to a system that, for example, might have a higher preponderance of primary care providers and fewer specialists. And even though everybody gets the same amount of money, the system ends up paying less because there are fewer specialists and more primary care physicians. And hospital administrators make an inordinate amount of money. I know that, for example, at UPMC, the former I guess, CEO there was making something like $7 million a year, and he's probably not making the most, but it's an inordinate amount of money. And under a single payer system, a non-for-profit, not privatized healthcare system, we would not have that kind of profits going to hospital administrators. There would be a global budget, for example, for hospitals, and everybody would be remunerated equitably, but certainly not excessively.
Anna, we have another question. What should I ask my primary care physician about this issue? And you might also say, what should the questioner tell his or her primary care physician about this issue?
That is such a great question. And I encourage everybody at your next primary care visit to ask your PCP if he or she is either in an ACO, a Medicare ACO, and they're called, we didn't get into all the details, not enough time. They're called Medicare Shared Savings Program. They're very, very popular. And it could very well be that the physician belongs to a Medicare Shared Savings Program, which means that if you are on Medicare, on traditional Medicare, then you are automatically aligned without your knowledge or consent into that ACO. So it is important for you to ask your primary care provider, are you in an ACO? Are you in an ACO reach? Oftentimes, physicians do not know that themselves because, unfortunately, physicians have less and less agency, and it's not necessarily the physicians themselves that are making these decisions, but much higher administrative personnel that are making, or hospital systems that are making these decisions for physicians. And what should they tell them? Well, it's hard to opt out as a physician from an ACO if your institution has signed up for an ACO. It's not easy. I know of a physician who is fighting his institution not to be aligned himself into that ACO as a provider, and like a 1 year grace period, but I'm not so sure that it's going to be extended. So good question. Yes, do ask your PCP.
I know we have several more questions, so I think there's just time for very brief answers. One questioner points out that Kaiser for seniors is always a Medicare Advantage plan. And this questioner feels that Kaiser does a pretty good job. How does that fit into the whole topic of privatization?
Well, Kaiser makes an awful lot of money from Medicare Advantage and has been accused of fraud. So I will keep this brief, but I think that most Medicare Advantage plans can be very, very good and very inexpensive as long as you are healthy. And once you start to need healthcare, then that's when people run into trouble.
Okay, another question. Is the essential difference between Medicare Advantage and an accountable care organization, is it that Medicare Advantage is upfront about being private insurance, but accountable care organizations look like Medicare, but actually are different?
I think that's a fair statement. I think it's a fair assessment.
Another questioner wants to know if AARP is involved in helping to prevent the problems that you've pointed out.
Unfortunately not. AARP sells Medicare Advantage plans through United Healthcare, so they are involved in being part of the problem. And as a matter of fact, I also believe that I remember reading something about them being involved in an ACO REACH.
We have a question about how to make this information part of the larger public discourse, and I'm going to wait because Linda Mahan may partly address that, and you can come back in later, Anna. So I'm going to go to the next question. Is it true that US doctors pay more for medical school and malpractice than in other countries, and that students often graduate in other countries with no medical debt?
That is true. US doctors do pay a lot more for medical school, and I think that the average medical school student debt is like $200,000 or maybe even more. So and in many countries, that's just not the case, because most other countries have public medical schools. And you know, you might need to pay for your books, but certainly not the amount of money that you have to pay for tuition in the United States. And regarding malpractice, yes, I think that American doctors typically do need. I can compare to Canada and in the United States. For the most professions do need specialties end up paying more for malpractice than in Canada. We are a little bit more litigious society than, say, the Canadians, but in the end, the number of healthcare costs are not driven up by malpractice. That's not really a number one driver of healthcare costs.
We're not going to have time to go into every other question. We may try to answer some of them in the email, but I'm going to close with a question about the salaries paid to hospital administrators and what proportion of healthcare costs that is. But I'm going to also just modify the question to say, can you comment about administrative costs? What do we pay overall for administrative costs, including hospital administrators, and how much of that is really essential versus waste?
Right. I think that you really, that the way that you're phrasing and framing the question is exactly the way it should be asked. And that is that our 20% of our healthcare dollars at least goes to administration. And that's probably twice as much, possibly close to twice as much as what other countries spend. I believe that Canada maybe has 15% administrative costs. The US is anywhere from 20 to 30. So, and I think that, you know, you wrap in all the administrator salaries and the CEO salaries, and there are thousands and thousands of people that need to do billing and administration and so forth, and that just adds to the huge administrative burden that the United States has, and that drives up our healthcare costs, as I was showing in my slides.
Thanks so much, Anna. We're going to bring you back later, but now it's time to go to Jodi Reid. Jodi has been for several decades the executive director of the California Alliance for Retired Americans, and she is going to continue the discussion.
Okay, thank you, Hank. And thank you, everybody, for being here. This is a really impressive group of folks who've joined us tonight. For those who don't know, the California Alliance for Retired Americans, or CARA, it's a lot easier to say, is a statewide advocacy organization comprised of organizational affiliates and individual members. And as of this year, we represent over 1 million older adults, people with disabilities, and their families through our combined membership structure. And we work on issues to improve the quality of life for seniors and people with disabilities, but really for everybody, because one thing that is true is we're all hopefully going to get older every day and eventually be seniors ourselves. And if we're not yet, we obviously have parents and family members and friends who are. So though we look at issues through the lens of our members, most everything we work on is intergenerational and will ultimately impact all of us. And the other thing that's true about our immediate members is that they're on Medicare. Some are on Medicare and Medi-Cal or Medicaid nationally based on their income. So they have a benefit package that brings the benefits and services of both of those programs together if your income is below a certain amount. But everybody is on Medicare from the lowest income to the highest income, unless they've chosen to opt out and haven't paid into it or aren't eligible for the benefit and are buying all of their medical care privately, which most likely means their income is high enough to be able to do that and kind of stay out of the system. And that's a very low number of people nationally and in California. So a lot of the ways that we decide what issues to work on and get involved in campaigns, both at the local, state, and national level, in terms of Medicare, is based on the things that are occurring to our members immediately. And so I'm going to talk about a couple of things that we're working on that we'd love for you all to engage in, either on an individual or organizational level. And the first thing I'm going to kind of talk a little bit more about is what Anna referred to, which is the AJR4, which stands for Assembly Joint Resolution 4, which was carried by Assemblywoman Pilar Schiavo, who's in northern LA County. So we learned about ACO REACH kind of from the experiential end, and then learned that there were these coalitions like the one Anna leads that were officially working on the problem of ACO REACH and these accountable care organizations. So many of our members who chose to be in traditional Medicare, meaning no middleman, were getting letters from health systems or health plans or limited equity organizations or Amazon, for example, saying that they have been assigned to a plan, a name of a plan, and they will be now receiving their care through that plan. And as an example, one of our members who received this letter didn't really know what the heck it was, but was going to the doctor in the next week or so. And when they went, the doctor told them, their doctor, the person who's been their provider for many, many years, that this would be the last time they would be able to see that provider unless they paid out of pocket, because they have been told that that person, they are not in the plan that that person was assigned to. Sometimes the doctors don't even know that either their patients have been assigned to a plan that they are no longer in, or that they've been placed in a plan and they didn't even know they were in that plan. So one of the really horrible consequences of this assignment to plans to people who are in traditional Medicare is that they no longer have choice of providers. And the beauty of traditional Medicare and why many people choose it is because they get their Medicare card and they can go to any provider they want. And now they can't. And or they find that the kind of specialist that they were seeing, another person who is a member, was getting very specific back care, who lives in Reading. And there were no specialists in Reading to do the kind of treatment that he is actually his wife required. And they had been going to UC San Francisco using their traditional Medicare choice of providers to get the specialized care. And when they learned that they were being put into this ACO plan, they could no longer go to UCSF unless they paid out of pocket. That's the human result for our members who are patients that made us realize what the heck is going on here, and we need to do something. So, and we were very surprised to learn that when Biden took office, we thought, let's just call Biden and his Health and Human Service Secretary, Javier Becerra, who is a Californian originally and one of our Congress members, and call the head of CMS and say, this was a Trump-inspired plan that just was done through executive order to create this ACO REACH system and give his buddies on Wall Street and other, hedge fund investors the opportunity to make money off of Medicare. And we thought we could just say to President Biden and his administration, can you, through executive order, just stop this practice? And lo and behold, we learned that President Biden and his administration are continuing this program that, as Anna said, was once called direct contract entities through when Trump established it, and the name, basically there was just a name change. So we passed a resolution as part of the campaign to put pressure on the Biden administration, calling on the California legislature to oppose the ACO REACH program and encourage the Biden administration to discontinue it through stroke of a pen. And that bill passed the state legislature. And the Secretary of State then was instructed to send a letter to the Biden administration and every member of the California congressional delegation, telling them of California's decision to oppose this and demand that the Biden administration end it. And now, as Anna mentioned, there's work to follow up individually with each of the members of the California congressional delegation, urging them to help us encourage the Biden administration to cease and desist in continuing this program. And so that is something all of you can do as well, and we can provide you with some of the tools to help you do that. But that was a big step. And we got a lot of not only attention in California by passing this legislation, but now we are being contacted by other organizations around the country to ask for a copy of the bill language so that they can try and do a similar effort in their own state and build public pressure and inform their state elected officials of what's going on and urge them to be part of this fight with us. So we're continuing to build on this. But that is not the only thing that is going on. We are looking at some legislation this year that will continue in the efforts to chip away at this ongoing privatization, because ultimately, as you saw with Anna's great slides, what this is ultimately doing by allowing Medicare Advantage plans and ACO programs to increase the percentage that they can take out of a Medicare payment up to 40%, 30%, 40% in profits and administrative costs. What that is doing is draining the Medicare Trust Fund, which is what pays for all of our Medicare services. And that Medicare Trust Fund, as it gets smaller and smaller, because we're giving profits and excessive payments to these private companies, it will mean ultimately less care for us as beneficiaries and patients, because there's not enough money in the pot to cover both. And it continues to put pressure on providers and insurers to cover less, possibly pay providers less, so there's less providers willing to and available to provide the services that we need. And ultimately is a real threat to the continuance of Medicare, which is a program that most of us pay into all of our working lives, with a guarantee that we'll have some health security when we're older and or disabled and retired. Instead of what our ultimate goal is, as Anna also mentioned, is our goal is to create a system that looks more like what Medicare was originally intended to be, which was a publicly financed healthcare system for everyone. That was the original goal of Medicare, and it didn't pass all at once in that form. And so then Medicare and Medicaid were created as a carve-out for the most at-risk populations, the lowest income and the oldest and frailest. But ultimately, the goal originally was to create a universal system. And we want to get back to that, where everybody gets the benefit, the same benefit, with choice of providers and at less cost to us as individuals, employers, and the government as a whole. That's a whole nother forum to talk about how that works. But that is our ultimate goal. And if Medicare Trust Fund is reduced through this profiteering, that money that would go towards building this universal system for everybody will not be available for us. Which leads me to the next and most recent attack. So many of you, CARA is a nonpartisan organization. We do education like you do. In fact, some things we've done together over the years with different league chapters. We try to educate older voters on the candidate positions. We do candidate questionnaires, we do forums, etc., so that people can make good decisions for themselves on who will best represent their interest and make their voting choices based on good information. And one of the things that we've been constantly having to fight against is unfortunately very partisan, which is that since Medicare was enacted, and Social Security too, but I'm not talking about that right now, the Republicans have always been opposed to it. There was never a Republican who voted for the original implementation of Medicare and Medicaid, and over the years have always been more likely to vote to cut and ultimately privatize, which they're getting their wish on Medicare, and let the private market deal with providing care. And one of the most recent results of this, and it takes different forms, but when McCarthy became the speaker after 15 votes, he made it his pledge to the GOP caucus in order to win those votes that top of his priorities is cutting and privatizing Medicare, Medicaid, and Social Security, and kept throwing into budget votes and debt ceiling votes. The criteria to get Republican votes means voting for proposals that will begin to do that, raising the age, cutting benefits, and privatizing were all part of the proposals. And fortunately, the president said, no way, no how, I'm not going to be hijacked into making a promise like that in order to do what you should be doing anyway, which is dealing with our budget and our debt ceiling issues. So what they did under the new speaker is they rushed through this proposal that has been tried before, even under Clinton, and passed a bill that would create a fiscal commission or a debt commission that would give authority, if passed by Congress, to 7 people who would become this commission, who will review proposals to save, under the auspices of save Medicare and Social Security, and then come to make a recommendation that they will present after the election, so this can't be held against them during the election season, make a recommendation to Congress that they can only vote up or down, no hearing, no discussion. All the discussion is going to be behind closed doors by this commission. And then the public will have no say. And the commission will make their recommendation to this body, to the full Congress. And remember, in November after the election, we will have a lame duck Congress because some of those folks will no longer be with us after the new year. And it's been, right now, Congress is led by Republicans by a very small margin, but still a margin. So if the entire Republican caucus was to vote for proposals to further cut, privatize, raise the age, whatever, it would pass by the Republican majority. So this is a very big threat to the most important, most popular programs in America. And because our members depend on both of those programs, that's what we are going to focus on, these kinds of issues that are being discussed today, to make sure every voter in particular target districts knows what's at stake on this ballot. When they're voting for a member of Congress or for a president or for a senator, they need to see where they stand on these kinds of issues, because it could determine how the programs that they depend on for their health security and their income security will be protected in the years to come, and certainly for their children and grandchildren and beyond. So we're going to provide to you with, thanks to Hank, this follow-up information. We're going to send you, there is a congressional letter that has been signed already by about 100 members of Congress across the country. Their names are listed on this letter, urging the rest of the congressional delegation to oppose this proposal that will be brought to them by the House Budget Committee for a vote to establish this fiscal commission. We'd like to nip it in the bud and stop it before it ever gets voted on, because conversations about the future of these programs should be held. There should be hearings, and the public should be involved, and all of the stakeholders need to be involved in this conversation, not 7 people who have an eye on destroying or at least privatizing further these programs. So you will get that, and hopefully all of you, regardless of where you live, you all have a member of Congress, and you can look to see if your member has already signed on to this letter, and if they haven't, encourage them to do so. So you'll have a copy of this to see who's done what, and hopefully make that call. And then finally, this year, we're in the process of developing some next step legislation on Medicare and Medi-Cal, and the privatization efforts happening in both of those that are still being developed by the authors of the legislation. So we will have those ready for public presentation and conversation once the final I's are dotted and T's are crossed. But the deadline to introduce legislation in California is February 16th. So it's upon us. So I want to thank everybody for being here. We're much, we are part of the fight to, one, protect, improve, and expand Medicare right now. And ultimately, our goal is to merge it into a larger guaranteed health care system for everyone, not just people who are older or disabled, so that we all get the care we need, that we can afford, have choice of providers, and save money. So I think that's it for me. I don't know if there are questions. Yeah. Hank, are you doing questions?
Jodi, I don't see any questions specifically for you.
Okay.
And we only have a couple of minutes before we want to bring on our next speaker. But let me see if there were questions that were submitted before you began, or that aren't specifically for you, but that you might be able to speak to. Well, one of them is about accountable care organizations. The questioner wants to know how those organizations get approved. Who does it?
CMS,
Which is?
the Center for Medicare and Medicaid Services. Ultimately, they approve these organizations. And I think Anna shared in one of her slides, and I can't remember the number, of how many have been approved so far and how many beneficiaries that covers. And I think in California, there are over 100 accountable care organizations that have been approved that serve at least California as part of their population.
Okay, two more questions, if you can give very brief answers. So one of them is, would a single payer healthcare program in California address some of these problems that we've been discussing?
Yes. That's a simple answer. Yes. Because there would be global budgeting for hospitals, which is part of what Medicare covers, as Anna mentioned. So they have to submit, hospitals have to submit a budget and get it approved, and then they have to work within that budget to pay for care and supplies and services, et cetera. And American Hospitals is a movie I highly recommend to everybody. If you have not seen it, it's now, you can now watch it on streaming services if you type in American Hospital, and it is a whole documentary about the cost of hospital care and what global budgeting is, and the importance of moving to a unified financing system, which is a single payer system that would solve not only some of the costs of hospital care, but care in general, rather than getting into all the details. But if you are interested in learning more about how single payer would save money and provide better care, and deal with some of these issues, we have done a lot of forums ourselves at CARA, and they're on our website that were recorded. You can go to www.californiaalliance.org, and you'll get that too from Hank in the follow-up to today's event. And we'd be happy to come and talk with you or your organization more about single payer specifically and how that deals with a lot of these issues.
Yeah, I can just add that single payer is a publicly governed, publicly financed nonprofit system. So it's the antithesis of privatization of healthcare delivery from top to bottom. Well, thanks so much, Jodi. And now it's time to introduce Linda Mahan. Linda is a longtime leader in the League of Women Voters from Larimer County, Colorado. And Linda is one of the founders of a national network of League healthcare activists that's been meeting for a couple of decades. Linda, the floor is yours.
Thanks, Hank. Can you all hear? All right.
Yes.
I appreciate the opportunity to join the group tonight. I am coming to you from Colorado, where I've lived for 45 years and have been really pleased to connect with leaguers across the country around our healthcare advocacy and action. And what we want to do now is talk a little bit about how, with the excellent background that our presenters have provided us, we can consider how we move forward, which is one of the questions that came up in the chat too. What we learned and how we can keep this conversation going in our communities, not only among our league members and organizations and networks, but in the wider community and to our healthcare providers. So one of the ways that, specifically speaking to the leaguers, is to join the national network of our members who meet monthly on conference calls. We have a newsletter. We have an opportunity through a Google group to share resources and ideas and energy with one another about how we're working in our communities around action. And we have a toolkit we developed also with lots of materials, suggestions of books, films, forums that you could present. So I encourage any leaguers to look for that information on the handout that comes out following tonight. Now, for the league, you know, we can take this information and act individually when we talk with legislators or our friends about this. But in the league, we do have some parameters around the kind of action that we can take. The league does both education and advocacy. Advocacy in the league is based on member study and agreement on selected issues. And thereafter, it's called our positions, which we use as the bedrock for the concerted efforts that we work to achieve those public policies, which are consistent with the positions. Education activities involve the information about public issues, including those on which we have a position. And in that education, we provide unbiased, factual information to citizens that they use as a basis for reaching their own decisions. So in keeping with this conversation going on about healthcare reform, I wanted to just mention a few of the things that our league has done around the education and keeping the conversation going in our communities. We have had Medicare birthday parties at our farmers markets and at our senior centers, where we pass out literature about the benefits of Medicare for all, improved Medicare for all, which is something that we can advocate for, as long as we're not giving a specific bill number name until we would get a call to action from the National League. We also have offered postcard campaigns where we invite people at the farmers markets or other events to send a letter to their member of Congress saying how much we love our Medicare and we wish everyone had Medicare. And what can you do to get Medicare for all? We've also done, as Jodi was mentioning, a lot of film showings, Sick Around the World, the hospital, American Hospital. We have shown that in community settings and then had panels of discussion talking about that just to keep our citizens informed about the high cost of healthcare. Many people don't understand much about their health insurance, and this is kind of our effort to help unpack some of that. We've marched in parades, Medicare for all signs. We have had our elected officials at the city council and the county commissioners pass resolutions supporting Medicare for all, and there's a large campaign that Public Citizen operates to do that. And we've had book studies by Zoom, certainly during the pandemic and before that in person, and writing letters to the editor, columns in newspapers are all things that we do just to kind of mention that, you know, we've got problems with our healthcare system and there are ways that you can learn more from the league or other organizations and then make your preferences known to our elected officials. We also have had allies in the work that we've been doing. You know, in California, you have CARA, and there are other local chapters of Physicians for a National Health Program that we have allied with, as well as other universal healthcare organizations. So what I'd like to do with my last 5 or 8 minutes is to ask any of you who are working in your communities to write some of the suggested activities that you've done or you've dreamed about in the chat, and I will read those so that we can kind of share these with one another and spread our ideas and our energy around. Now, let's see, I need to look and see if you put that in the question, actually you need to put it in the Q&A. That's our way to get feedback into us all. And thinking about what strengths your league brings to bear on this in the community, and who are your allies. Those are kind of the questions that would frame a conversation that we could have a little bit tonight, or we could, you could take those back to your leagues and start the conversation. And Hank, can you help me look for these also, if we get some suggestions?
Linda, I'm looking in the Q&A.
Mm-hmm.
I'm
There
not-
was the one question, how can we keep this conversation going?
Yeah.
And I think that's where we're really talking about tonight. The other thing that we have done with our legislators who hold town hall meetings is that when we go as individuals to those, we can ask questions. You know, I'm concerned about the high cost of my prescription drugs, or I'm concerned about, you know, my practice has been taken over by an ACO, or, you know, and what can I do? And what are you doing in the Congress? So those are questions that we can raise to elected officials that lets everyone in the room hear them, but also may let those elected officials know that, you know, this is concern and we expect them to step up and have some leadership in their position.
Linda, can you give examples of experience that you've seen or heard about where some of this education that you've been describing has actually led toward resolution of some of the problems that we're talking about? Do you think it's pointed toward you know, a transformative solution that gets to the core of any of these problems?
It's a big problem. I'll tell you, after 20 years, I'm not sure. But I know that there has been an impact in our congressional district, because we did succeed on several occasions of meeting with our members of Congress to talk to them about what they were doing and making sure that they understood the concerns, and that the petitions or the postcards that we collected from, you know, hundreds of our constituents let them know that people in our community care about this and we want them to do something. So I think the other piece that I think is a benefit is that we are trying to help empower citizens and engage them in this political process. So that's part of the League's mission also, is to get citizens engaged and give them some agency in speaking with elected officials.
Linda, another question. Those of us who are members of the League or considering joining the League feel that the League is an important organization and can contribute to making our democracy function better. So the question is, what has been the hesitation of the national organization to take a position on the 2 Medicare for All bills that are now in the House and in the Senate?
Well, I've never gotten, well, I don't know whether I have a direct answer from the National League on that, but I know that over the years they've been hesitant to step out on something that they felt was not politically really possible at the time. So I think they want to keep their seat at the table. And perhaps if they see no path forward for legislation passing, they may not jump on the bandwagon. But as I can say, that's just my hunch or hypothesis, because they don't really say in so many words that they don't step out on that. I think the groundswell, and what I keep believing, is that the groundswell of the grassroots of the league, having more and more people in the membership understand this, working with allied partners, and getting the community conversation and demand so that our elected officials must step up and do something, is where we have a role to play.
I think at this point, we'd just like all the panelists to be prepared to answer some questions, and you can, chime in and supplement. But I'm going to start by going back to a question about Medicare Advantage. And the question is, when people make decisions to join, either to join Medicare Advantage or stay with regular Medicare, and I think we've already heard that sometimes decisions are made for people, not by people. They're made behind the scenes. But when people do have that opportunity to make a decision, do we advocate that that choice be limited? And the questioner says some people are happy with their Medicare Advantage and with their care overall, and some Medicare Advantage plans have high customer satisfaction. So would anyone like to go first on that?
I will take a stab at it. We get this question all the time because we're a primarily senior organization. And so people constantly ask us, are you telling us not to sign up for Medicare Advantage or not to choose traditional Medicare? And what our answer for right now, because we haven't transformed the system yet, that's our ultimate goal, is if you are happy with your provider, you're happy with the services you're getting, you're able to afford the services you're getting, and that's what's keeping you healthy and secure in your future health, don't change. This is the world we're living in right now, and it is very imperfect. But your health is your that's your personal decision. And we're not suggesting that you make radical changes to the healthcare you're providing if you are getting the care you need and you're satisfied. We're not suggesting you make a big change for some political reason. This is personal, and you have got to take care of yourself and pick what works for you. Now, all of you who are on Medicare or who know people who are on Medicare are probably quite familiar with what happens between October and the end of December, which is considered open enrollment for Medicare. And if you are not happy with your providers or the quality of care or the services that you're able to get through your current health care plan, whether traditional or Medicare Advantage or ACO, that's the time of year that you can change. And in California, it's hard there are so many choices, thousands. When I came on Medicare, and I'm going to take a picture of this sometime, I got in October thousands of brochures, inundated, and I saved them, and they're in like a post office crate because there were so many of them, just to sort of see what are they going to send me. It's really hard to make those choices. So if you're in a situation where you're unhappy and you want to know what options there are, in California, there's an organization called HICAP. It stands for Health Insurance Counseling and Advocacy Program. It's a mouthful. And every county has a HICAP program with counselors that will help you, show you what the plans are and what they cover. And if you want to know if a medication that you're taking is covered, they can figure that out for you. So you won't want to choose a plan that doesn't have your medication in their formulary. So there is advice out there if you decide to choose a new plan at some point. But if you're happy with your providers and you're happy with your plan, don't change. What we're talking about is a big healthcare reform transformation that is our ultimate goal, so that we won't have to make these kind of choices. Everybody will get the same standard benefits with vision and dental and long-term care, which Medicare does not cover, and the other services that we all need. But we're not there yet. So now we're kind of picking away at some of the really terrible problems. But that is not at the risk of you losing your care. That's the most important thing.
Anna or Linda, do you want to add anything?
I would like to just say a couple more things. Jodi is absolutely 100% right. I get this question asked a lot. People say, well, you know, I'm really against Medicare Advantage, but I'm on Medicare Advantage. Should I switch over to traditional Medicare? No, it's not like a political decision that you're making here. It's a health decision. Now, having said all of this, when people say, well, I want to switch, after the 6-month period of your initial enrollment into Medicare, after you turn 65, in most states, other than 4 states in the country, it is incredibly difficult to switch out of Medicare Advantage once you have chosen Medicare Advantage to go back into traditional Medicare, even if you can afford it. Those states are Maine, Connecticut, New York, and help me, Maine, Connecticut, New York, Massachusetts. Outside of those states, once you have chosen Medicare Advantage, 6 months into your choice, you will find it incredibly difficult to move back to traditional Medicare. So your choice then, yes, during open season, which that's what I like to call open enrollment, open season, is to go from one Medicare Advantage plan to another. If you are on traditional Medicare, then I believe that you can switch from one supplemental plan to another. But the biggest problem is that Medicare Advantage is not really a choice for most people. Medicare Advantage is something that they're forced into because of finances. Medicare Advantage is a lot less expensive for most seniors. And most seniors, particularly that live on a fixed income, cannot afford the $8,000 to $10,000 that it will cost them every single year to pay for the Part B premiums, the D, the supplemental plans. It's very, very expensive. And as a consequence, when people see the low to no premiums in Medicare Advantage, that's what they end up choosing, even though it's not really a choice. They're being forced into that. And I agree. I think that if you have questions, particularly if you are just new to Medicare, then definitely you want to speak with one of those high cap counselors. They're also known as SHIP counselors. And I think that they can give you very unbiased and fair information about what you can do or what you should do. But it's usually a financial decision that people make, and it's not because they really love, United Healthcare.
Anna, you've touched on something that sounds a little paradoxical, which is that for individuals, Medicare Advantage programs may cost less. And yet, I think you said earlier that Medicare Advantage programs and ACOs in many cases cost the Medicare system more. So is it fair to say that the way this game is rigged is that private corporations, whether they be for-profit or not-for-profit, are using their access to taxpayer dollars to subsidize lower cost insurance for their individual enrollees? Is that the way it comes together?
Yes, absolutely. That's what's happening. And then what ends up happening is that because, as Jodi was saying, they're siphoning off money from the Medicare Trust Fund, in order to make up for the fact that they're overpaying Medicare Advantage, they have to increase the Part B premiums. that affects people on traditional Medicare, plus the people in Medicare Advantage, because they have to pay the Part B premiums as well.
The other thing that happens too is that these plans, as Anna shared in her slide, they get a certain amount, it's called capitation, for every Medicare beneficiary they sign up into their Medicare Advantage plan. And if they have a profit motive, which most of these private companies do, it's a huge incentive to instruct their providers in that plan to reduce services or to not recommend certain services so that cost more, so that they can keep more in their profit column. So they get to keep more of that monthly capitation for healthier beneficiaries, and there's a very unhealthy incentive to manage care, which is why they're called managed care, but often that means denial of care.
I think we have time for one more question, and it concerns labor unions. Not sure how many people in this webinar are union members, but most of us will know people, and we depend on the services and the products of union members, and we know that they're an influential segment of society. So the question is, are unions also subject to being pulled into accountable care organizations, and how are unions? What's the impact on unions? What is their view of this question? If you're a member of a union or the leader of a labor union,
That's a really good question. And CARA is made up of community-based organizations and labor union retirees. So we are very engaged in this conversation with labor. It's really complicated. So a lot of labor unions have labor management committees that collectively decide on what benefits will be part of the union contract. But they also have, I'm not going to get into all the details of it, but also they are benefiting in some ways from being able to provide the union members with a health benefit as part of their contract. And there's a lot of finances tied up in that with the actual managed care entities. And so as we look to move towards a Medicare for all or unified financing system as a transformative act, we have to address the very intricately tied benefits that are part of a union contract, and pulling those apart and showing how the unions not only would benefit. Right now, health benefits are the #1 issue at the bargaining table because prices keep going up for purchasing healthcare and providing insurance to members and employees, and people are being asked to pay a higher and higher share of the cost of healthcare, where in previous years maybe the union provided full coverage. Now they can't because the prices are going up, so they're putting pressure and telling their workers, if you want full healthcare benefits in this next contract, it may mean we have to give up wage increases or other health and safety standards because the cost of healthcare is so expensive, we don't have enough money to pay for that. And so it's at the bargaining table every single day, including retiree benefits that might have been part of the contract. So it is undeniable that labor is in this fight, and they are dealing with the pressures, and they're trying to figure out how to unravel themselves from their previous relationships with insurance companies and benefit managers so that they can provide better coverage. It'd be great to take healthcare off the bargaining table. If everybody had coverage with the same benefits at the same cost, we wouldn't have to bargain for healthcare. We could focus on wage and working conditions and other things. So we're trying to make sure that labor is at the table here. because they have a lot to gain by simplifying and providing more equitable coverage for everybody. So this is part of what is being discussed. What we're doing here is happening in labor unions as well, or at least some of them.
Yeah, I would just add that unfortunately, I think that there has been a loss of the support from labor for Medicare for All. However, I don't know if all of you read a great piece written by Sean Fain, the president of the UAW, in The Nation recently, where he said that by 2028, the three big demands, I think, are going to be $30 an hour wage. Second one, I don't remember. And the third one is Medicare for All. So I think that they might be back in the fight.
Well, thank you, all our panelists, and thank you, participants, for staying with us. We're a few minutes over time. So at this point, I want to bring on Candia Mosley Gandhi, our local league president, to just wrap up. Candia?
Yes, thanks, Hank. And thank you, CARA, for sponsoring tonight's educational event. I also want to thank all of the panelists who came and shared such important and rich information with us this evening. If you are not already a member of the League of Women Voters in your community, we urge you to become members. This month, we're actually kind of in the height of our recruitment season through the end of January. So please do consider joining the League of Women Voters. And if you live in Berkeley, Albany, or Emeryville, join the local league. And you can check us out at lwvbae.org. And that's about it. Thank you, everyone, for attending.
Thank you.
Good night.
Thank you.
Take care. Bye.